Thank you, sir. Representative Srinivasan of the 31st, sir, you have the floor.
Thank you, Mr. Speaker. Good afternoon, Mr. Speaker, again to you.
Good afternoon.
Thank you. As our good chairman of Public Health mentioned in his opening statements, this is landmark legislation for us here in Connecticut. We definitely have, unfortunately, an overdose and an opioid abuse problem. It's not just a problem, it's an epidemic. This epidemic has impacted our cities, our towns, both urban as well as rural areas. It has not spared any socioeconomic group. It does not matter how educated or not so educated a person is. It is impacting the lives of practically each and every one of us here in our state. And I'm sure in this chamber alone, we can have stories after stories of how the opioid abuse has impacted our lives, directly or indirectly. This bill, as amended, House Bill 5053, is definitely a bipartisan attempt to stem this epidemic. As the good chairman said, we have touched upon the availability of Narcan, making it more accessible because it is a lifesaver. The council has now been charged with coming up with data on how many lives have we been able to reduce in terms of opioid-induced deaths. The duration of a narcotic, the centerpiece of this legislation, whether it be 7 days in Section 7 or in Section 11, where we're going to study and say, is 7 the right number, or should we be looking at a different number? And finally, the important section about the drug monitoring program, so that, as the good chairman said, the doctor shopping or the shopping from one medical facility to another, if it were to happen, it can be easily picked up because of the monitoring programs. So this bill, bill as amended, is definitely a landmark legislation, something that each and every one of us should be proud of, so that we make our towns, our cities, our entire state far safer than what it is today. Mr. Speaker, through you, Mr. Speaker, more than a few questions to the good proponent of this bipartisan bill. Through you, Mr. Speaker.
Please proceed, yeah.
Yeah. Thank you, Mr. Speaker. Through you, Mr. Speaker, going through this bill section-wise, and I know a lot of my colleagues have questions on this bill as well, for the right reasons, so that we clarify. If you look at lines 38, and if the good chairman can tell us, in each municipality, who will be responsible to make sure that Narcan is available?
Representative Ritter.
Mr. Speaker, through you, the question is, it depends. And so we had different drafts in committee, and I know Representative Perillo took a great interest in this and worked with the OPM on this. What we've said is the towns, through their local plans, will sort of figure it out. And what we're leaning towards is who's going to be first on the scene. In some cases, it's fire. Some cases, it's police. I know in Hartford, it's our firefighters. It doesn't preclude them both from carrying it or from the state trooper carrying it, but we're looking at who's going to be first on the scene. They'd be the ones who would carry Narcan and have it be mandated by state statute, through Mr. Speaker.
Representative Srinivasan.
Through you, Mr. Speaker, so each municipality then, as I understand it clearly, will decide as to who is the first responder, whether it's a state trooper, it's the police, it's a firefighter, and depending on that, it is the municipality that will decide as to who will carry Narcan, and not something that we mandate from here, from Hartford.
Representative Ritter.
That is correct, through you.
Representative Srinivasan.
Through you, Mr. Speaker, could the good chair tell us what is the likely cost for this prescription of Narcan?
Representative Ritter.
To Mr. Speaker, the numbers I recall seeing were no more than a couple $100s. Larger municipalities may have run closer to 1,000, but it is not a large cost. And again, none of the large municipal organizations, CCM or cost, oppose this through you.
Representative Srinivasan.
And through you, Mr. Speaker, what is the shelf life of these Narcan that these municipalities, we're now requiring them to carry? Through you, Mr.
Representative
Speaker.
Ritter.
Mr. Speaker, off the top of my head, I believe it was less than a year. I cannot remember exactly what it was, but I know it was less than a year for the shelf life, but it was more than a few months through you.
Representative Srinivasan.
So through you, Mr. Speaker, so that I'm clear, so the cost the good chair said to each of our municipalities would range probably in about $1,000 is what I heard. I just want to be clear on that through you, Mr. Speaker.
Representative Ritter.
It could certainly get that high for smaller towns. And again, most large municipalities already carry it. It was a lot of the smaller towns that didn't. It's going to run far less than $1,000 through you.
Representative Srinivasan.
Through you, Mr. Speaker, in Sections 2 and Section 3, moving on with the bill, where we require individual health insurances and group health insurances that they will not require prior authorization if this prescription were to be written by a healthcare provider. Am I reading that correctly through you, Mr. Speaker?
Representative Ritter.
That's correct. There can be no prior authorization required from either an individual health insurance policy or a group health insurance policy through you.
Representative Srinivasan.
Through you, Mr. Speaker, prior authorization is not required, but will a copay be required if it is so as far as the coverage for that particular individual is concerned? Through you, Mr. Speaker.
Representative Ritter.
If a copay would be normally charged, it can be charged here through you.
Representative Srinivasan.
Through you, Mr. Speaker, this copay, would it be, as we all know, come in multiple tiers, Tier 1, Tier 2, Tier 3. Are we mandating or requiring as to what copay these insurance companies can charge people when this prescription is written? Through you, Mr. Speaker.
Representative Ritter.
Through you, this bill does not tell insurance companies what the copay must be through you.
Representative Srinivasan.
Through you, Mr. Speaker, in Section 4, the Council has laudable goals. And how will the Council report back to us the charge that we have given them in terms of the debts and accounting for all of that? Through you, Mr. Speaker.
Representative Ritter.
Through you, Mr. Speaker, they come up with a plan, lines 112 through 114, highlights that by 1117, we'll have a plan to reduce opioid-induced deaths in the state from this council, which is new. That report would probably be a public document shared with the governor's office and the committees of cognizance through you.
Representative Srinivasan.
Through you, Mr. Speaker, the council is now enlarged with subcommittee members. Will these subcommittee members all be voluntary? Through you, Mr. Speaker.
Representative Ritter.
Through you, they will be volunteers, yes.
Representative Srinivasan.
Through you, Mr. Speaker, Section 5 talks about the certification, which now will not be maintained by DPH, but by the National Acupuncture Detox Association. Is that the only association that will maintain the certification? Through you, Mr. Speaker.
Representative Ritter.
Through you, to the extent they practice the 5-point auricular acupuncture protocol, then yes, through you.
Representative Srinivasan.
Through you, Mr. Speaker, what role will DPH have as far as these certifications are concerned?
Representative Ritter.
Well, DPH still is involved. This just changes that instead of it generically saying an organization approved by public health, we specify what it is. It was an interesting group of persons who came in to meet with the Public Health Committee who do this, and just so people are clear, 5 points, literally 5 needles, go in your ear, and it has been proven very effectively that it can help with addiction. And so it's used across the state. They needed some clarification in the statute. That's what this does. But this is being utilized more readily by groups across the state to do.
Representative Srinivasan.
Through you, Mr. Speaker, we now move to Section 7, which is obviously the centerpiece of this legislation. So through you, Mr. Speaker, for an adult, first-time outpatient, the maximum number of days that the opioid can be prescribed is 7 days. Is that right? Through you, Mr. Speaker.
Representative Ritter.
That is correct unless subsection D, beginning on line 195, is triggered by the physician who's prescribing it through you.
Representative Srinivasan.
Through you, Mr. Speaker, does it matter for the 7 days for the first time whether it is an MD or a consultant who is a pain management consultant. Through you, Mr. Speaker.
Representative Ritter.
Through you, it's whoever the prescribing practitioner is. Through you, Mr. Speaker.
Representative Srinivasan.
So through you, Mr. Speaker, regardless of whether it's a family practitioner, internist, or a pain management, they still have, for the first time, unless in subsection has been moved down, it will be a maximum of 7 days.
Representative Ritter.
That is correct. Through you.
Representative Srinivasan.
And this applies through you, Mr. Speaker, only for the very first time. So if they were to come for a second time, this restriction of 7 days does not apply.
Representative Ritter.
That is correct. Through you.
Representative Srinivasan.
Through you, Mr. Speaker, moving to children. So will the same restriction apply that when they come in, it'll be a 7-day maximum supply, regardless it is by a pediatrician or a pain consultant? Through you, Mr. Speaker.
Representative Ritter.
That is correct.
Representative Srinivasan.
Through you, Mr. Speaker, if a minor, I mean the parents, of course, bring the minor for a second time or a third time for the same condition, will it still apply that it can only be for 7 days?
Representative Ritter.
Again, unless we trigger subsection D, the answer is yes, 7 days, all times.
Representative Srinivasan.
Through you, Mr. Speaker, in lines 186, we talk about the pediatrician or the prescriber shall discuss, document, and chart this discussion that they had with the parent before prescribing the opioid to the minor. Will this be a discussion which will then, of course, be documented in the chart that such a discussion took place? Or will they have to get a written consent that this discussion did take place and it is documented in the chart? Through you, Mr. Speaker.
Representative Ritter.
So, Mr. Speaker, the words here just say shall discuss. It doesn't mention putting it on a chart or something like that. Again, though, when we put sort of a standard of care in a state statute, one would assume that not only would it be complied with, you'd want to find a way to document that compliance. Through you.
Representative Srinivasan.
Through you, Mr. Speaker, there's a big difference between documenting on the one hand, which of course every provider will have to do, and getting a signed document. So through you, Mr. Speaker, I want to make sure, is it just documentation or is it a signed document? Through you, Mr. Speaker.
Representative Ritter.
Again, there's no reference in here to a signed document of any kind. It's a discussion that they must have with the minor, and if the parents are there, then they can also discuss with the parents. Through you.
Representative Srinivasan.
Through you, Mr. Speaker, when it goes to more than 7 days at the discretion of the provider, as the good chairman alluded to, even if it is for the first time, will it only apply for cancer or palliative care, or could other conditions be also there where the physician could decide that the treatment needs to be for more than 7 days?
Representative Ritter.
It certainly can go beyond that. The term we use is acute medical condition. And let me tell you why this is important. A lot of you may have gotten emails from people who suffer from something. I got a lot from people in my district, actually, who take it for very painful arthritis or things like that. And so working with the medical society, we want to be careful. Opioids have, as we know, that's why we have the bill, had some awful repercussions in our society. They also relieve a lot of pain. They do help a lot of people, and you can't deny that. And so we wanted to make sure there was flexibility so that someone who has been taking maybe an opioid for years to treat a chronic condition or an acute medical condition wasn't now limited to 7 days or have to go back and forth with the doctor and the prescribing practitioner. So we believe that this subsection does two things. It gives doctors the flexibility to practice their craft, but also it makes them then say in the file why they overrode the underlying policy considerations in the bill. Through you.
Representative Srinivasan.
So through you, Mr. Speaker, if the provider in his or her infinite wisdom feels that the number of days that need to be prescribed are more than 7, obviously has gone through the thought process, has discussed that with the patient, and documents obviously that in the chart as well. Nothing in what we are passing today, if it were to become law, would prevent that from happening. Through you, Mr. Speaker.
Representative Ritter.
That is correct.
Representative Srinivasan.
Through you, Mr. Speaker, as a good chairman said, I've had a lot of requests, a lot of emails from people saying that it is going to be very inconvenient for them because they've got to keep going back now to get the prescription filled. The inconvenience factor, of course, is minimal compared to the problem that we have in the state. But what they're equally concerned, along with the inconvenience of going to get the prescription, will they have a copay every time they go into the physician's office to get the prescription and thus increase the cost? Because now is no longer 30-day supply, it's a 7-day supply, and they keep going back because they do need it beyond the 7 days. Through you, Mr. Speaker.
Representative Ritter.
Through you, we did check with the insurance department, and there could be multiple copays. And as a policy decision, we have to ask ourselves, are we comfortable with that, given the amount of supply we're reducing, as we talked about, in the opioid prescription world? But again, if you think about it just from more how it would work out practically, if someone really needed 2 7-day supplies, well, they might pay 2 copays. It might be true. But if they were really looking for long-term treatment, if it was going to run 30, 60 days, if it was going to be all year long, presumably the prescription amount would just go up, and that would limit the amount of copays. But that is something that certainly could happen to somebody, just like with any other medicine you get prescribed. Through you.
Representative Srinivasan.
So through you, Mr. Speaker, on a short-term basis, since we're restricting to a 7-day supply, if I heard the good chairman well, we could incur A, an inconvenience, and B, a second copay. But if somebody was on a long-term treatment program, obviously, then there is no restriction here, as a physician could write for more than 30 days or 60 days. Through you, Mr. Speaker.
Representative Ritter.
That is correct. And most do 30 days. Frankly, that's really what happens in reality. But if you didn't have subsection D and that override authority, you could have a situation where someone had to keep going back 7 days, 7 days, 7 days, 7 days. And so we tried to avoid that, and that's what the negotiations and discussions led to this language. It greatly mirrors Massachusetts, and we're the only 2 states, if this passes, in the country that have this. I'd be shocked if within 2 years, more than half of the states in the country didn't have a similar law. Through you.
Representative Srinivasan.
Through you, Mr. Speaker, going to Section 9, which is about the drug monitoring program. So as I understand it now, this legislation will require pharmacists to enter the data within the next business day. So through you, Mr. Speaker, if the good chairman could enlarge on what is the next business day.
Representative Ritter.
Yes. So it used to be 24 hours, line 264. So the next business day is just that. Here was what the pharmacists were saying. If it happens on Friday, we might be gone for the weekend. Can we do it on Monday? Also, if the prescription comes in late in the morning of Tuesday at 1 o'clock in the morning, right, 24 hours is 1 o'clock in the morning the next day. The next business day gives them a little more flexibility. We're not gutting the program. We're making it more workable. And kudos to Consumer Protection for noticing this, working with pharmacists. We can't be so rigid in our application of laws that we don't listen to people. That's exactly what this did. It listened to people to make a common sense policy change. Through you.
Representative Srinivasan.
So through you, Mr. Speaker, so that the pharmacists are clear, because they have approached me confused on this piece of legislation, and I want to make sure we are clear on that. So when we say the next business day, are we looking at a business day from a banker's point of view or from a pharmacy that's open 24 hours? As we now know, a lot of pharmacies are open. Through you, Mr. Speaker, for the example that the good chairman gave of coming in on a Friday at 6 p.m.
Representative Ritter.
Mr. Speaker, business day is a term of art. We use it a lot in the statutes. And every time I've read business day, it includes Monday through Friday. Now, the example of a 24/7 pharmacy just changed that. But without a definition clarifying it to the contrary, I would say it involves the normal weekdays that we think of. Through you.
Representative Srinivasan.
So through you, Mr. Speaker, so that I'm clear, and most importantly, the pharmacists are clear, that they would have to make sure that it enters into the system within the Monday through Friday 9 to 5 parameters. Through you, Mr. Speaker.
Representative Ritter.
Yeah, never mind. Take that all back. You can't be so rigid in your explanations that you won't go back and change them, too.
Correct.
281, they did define business day, and it is whenever the pharmacy is open.
Right.
So that's the clarification. I do apologize to the chamber for that error. Through you.
Representative Srinivasan.
Through you, Mr. Speaker, I read that as well, and that was why I was a little bit confused and wanted to be sure that what was and what is the business day as far as pharmacies are concerned when they are open 7 days a week and 24 hours. Through you, Mr. Speaker, and giving the example of somebody going in on a Friday at 6 p.m. So will it mean by Saturday 6 p.m. that should be entered in the system? Through you, Mr. Speaker.
Representative Ritter.
Through you, that would be correct. Through you. And again, sorry, Representative Rye, if I could finish that train of thought. Through you, Mr. Speaker. I'm glad that the good ranking member was aware of that. I just wish I had spotted it earlier. Again, my apologies.
Representative Srinivasan.
So now that we are clear, I just want to be sure that it is a 24-hour, from a time point of view, regardless of the 9 to 5, the conventional business day. Through you, Mr. Speaker. So the pharmacists will be held accountable, even if it is a long weekend or even if it is a regular weekend. Through you, Mr. Speaker.
Representative Ritter.
If they are open 7 days a week, then they have to make it the next business day. It could be more than 24 hours. It could exceed that, but it has to be the next business day. To smaller pharmacies that might be closed on Sunday, it could bounce from Saturday to Monday. Through you.
Representative Srinivasan.
Thank you, Mr. Speaker. Looking at veterinarians, they will have to participate in the drug monitoring program, through you, Mr. Speaker, only if they dispense, not if they prescribe. Through you, Mr. Speaker.
Representative Ritter.
That is correct. And what the vets said to us, the veterinarians did testify, some of them have gotten to the point where instead of dispensing directly, when I go to my veterinarian for Dublin, they give me the medicine right there. That is dispensing. What a lot of vets do now is they just call a pharmacist and make them do it so they can avoid this program altogether. Through you.
Representative Srinivasan.
Through you, Mr. Speaker, if a veterinarian dispenses, then that veterinarian has to report that within a certain time frame, within a week. Is that right? Through you, Mr. Speaker.
Representative Ritter.
Correct. So we gave them a longer window for veterinarians. We gave them 7 days to input the data, and also they can use an agent to do it. That was one of their complaints too. Vets were actually doing it themselves, so they couldn't deputize someone to do it. So they would have at least weekly. Through you.
Representative Srinivasan.
Through you, Mr. Speaker, as the good chairman said, we had passed a very important piece of legislation just last session. And here we are back on this session again discussing the drug monitoring program. And the reason for that is very simple. We heard from the physicians, we heard from the providers what their concerns were, what the stumbling blocks were. And what this legislation tries to do is to make sure we have listened to the providers and we take care of their concerns and their requests as well. So through you, Mr. Speaker, now to enter the prescription that has been written by the provider in terms of monitoring the program when it is given for more than 72 hours, which is where the window is, does the physician or the physician's licensed person only can look at that information? Through you, Mr. Speaker.
Representative Ritter.
That is correct, and I'd point the chamber to lines 350 through line 63, which discuss this, and the prescribing practitioner can designate someone to do it, to both review the program on behalf of the prescribing practitioner, which is one of the major concerns. Especially for a small office, to not have someone do it for you did take them time. So now someone can review the system to make sure, yes, there was a prescription given to Mr. or Mrs. Smith last week, and let the prescribing practitioner know. Through you.
Representative Srinivasan.
Through you, Mr. Speaker, because this, as the good chairman said, impacts a lot of small practices where they do not have a lot of help and they may not have licensed practitioners along with them. So it is up to the physician or the physician's practice to decide as to who so-called would be the authorized agent who will be able to look up on the monitor, inform the prescriber so that he or she can then decide whether this patient is doctor shopping. Through you, Mr. Speaker.
Representative Ritter.
That is correct. Through you.
Representative Srinivasan.
Through you, Mr. Speaker, is there any monitoring program or an oversight regarding these various agents who are now authorized to look at this information? Through you, Mr. Speaker.
Representative Ritter.
So one of the safeguards is that they can hold, they not shall, they may hold the prescribing practitioner liable for disciplinary acts if there's abuse. And so the real thought is to let offices control the authorized agent, and that is sort of the stick over them throughout that process through you.
Representative Srinivasan.
So through you, Mr. Speaker, if I heard the chairman well, it is a kind of a concept of self-policing. The physician is responsible, to delegate, and then has a responsibility of oversight of whom he or she has delegated this responsibility to. Through you, Mr. Speaker.
Representative Ritter.
That is correct. And Department of Consumer Protection always has oversight over every facet of the program as well, through you.
Representative Srinivasan.
And through you, Mr. Speaker, will this apply in a hospital setting as well, where the physician can then delegate somebody else to look at the similar information like what we see in a small private practice setting? Through you, Mr. Speaker.
Representative Ritter.
It does, and the next section gets into that. It's a little different. If you talk about the doctor's office where you have the one person sort of sits out front, sort of does your bookkeeping or does your scheduling, that'd be who you designate, and you have a direct relationship between the two. A hospital, so many more people involved, a different process. So we did for the hospitals, 375 through 377 is said the hospital can designate one person. Could be a medical director, a department head. All of them must be controlled substance registrants. And then they would sort of be the point person as the prescribing practitioner for the entire hospital. They would have oversight over the various agents that were authorized through you.
Representative Srinivasan.
Through you, Mr. Speaker, the good chairman mentioned that we in our state will be passing perhaps one of the strictest laws and compared that to what was passed in Massachusetts. Does Massachusetts also have a 7-day limit? Through you, Mr. Speaker.
Representative Ritter.
Yes, it is my understanding that the state of Massachusetts has a 7-day limit as well, through you.
Representative Srinivasan.
And through you, Mr. Speaker, my final question to the good chair, is Massachusetts also looking at lowering that 7 days to maybe 3 or 5 days like we intend to do? Through you, Mr. Speaker.
Representative Ritter.
I do not know if they've looked at that through you.
Representative Srinivasan.
Mr. Speaker, I want to thank the good chair for answering all these lengthy questions of mine. And as we said, this is a bipartisan support on this important piece of legislation, which will look at the multiple facets that need to be looked at so that at the end of the day, we address this important issue, very critical issue of opioid abuse and opioid overdose and unfortunately opioid deaths. Thank you, Mr. Speaker.